This week on the BackTable podcast.
The best operators in the country are operators who do not have one technique for all patients. I think even when we're talking about a laser, Auryon laser has been really great addition, but all other atherectomy devices should be available. And we're hoping that this podcast and other podcasts and some publication open the eyes for, the companies to start really investing heavily with radial to peripheral. We still need products that we don't have available, certain type of stent. Wires, extremely important. And we'll just hopefully, more operators start using radial and we learn from each other. And happy to hear from other people who just started, the challenges that they had, the concern that they had, and maybe the success cases also that they had.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. You can find all previous episodes of the podcast on iTunes, Spotify, or our website, which is backtable.com. Now a quick word from our sponsor. A patient with PAD can show symptoms in a variety of ways. This presents unique challenges when choosing a treatment option that is effective in improving outcomes across a broad spectrum of arterial disease. AngioDynamics Auryon system changes everything. Using cutting-edge laser tech that can aspirate anywhere, featuring a 355 nanometer wavelength and 25 nanosecond pulse width, the Auryon system conquers disease with science in a way no other platform does. With the most versatile laser on the market, the Auryon system is able to treat PAD, ISR, CLI, and ALI, whether it's above the knee or below the knee. Different from most lasers, the Auryon system's 3.5 photon energy allows it to spare the vessel wall while attacking lesions. This safety profile is why leading interventionalists have chosen the Auryon system to treat more than 25,000 patients over the last 2 years and deliver improved quality of limbs and lives. Visit auryon-system.com to learn more. And now back to the show. Our topic today is radial to peripheral, or R2P. And specifically, radial to peripheral laser atherectomy. Our guest today is Dr. Sameh Sayfo. Sam is interventional cardiologist from the Baylor Heart Hospital in Plano, Texas. Sam, welcome back to the show.
Thank you. Thank you for having me.
All right. So I said welcome back for Sam. You've been on 2 episodes, one with laser atherectomy where you were guest hosting with Fritz.
Correct. Dr. Matz was the guest for that episode.
That's right. And then Fritz did one where he interviewed you just for radial to peripheral stuff, right? Like radial to peripheral basics.
Exactly.
Yeah.
Exactly.
Okay. For those interested, the radial podcasts that are in the BackTable catalog, episodes 30, 148, 342, 395, and 443. And also, if you're interested, the laser atherectomy podcasts as we've done, 390 and 408, and now this one. So Sam, I know that you've done it before, but just for anyone who hasn't caught the old episodes, will you just give us a quick background, training, and what your practice looks like?
Yeah, definitely. Well, thank you for having me again. So as I said, I'm an interventional cardiologist and by training, but with a lot of big endovascular practice. I graduated my interventional cardiology from Brown University, and over there is a lot of focus on endovascular therapy, and we train a lot. So when moved to Dallas, or specifically the Heart Hospital Plano, that's something that there was a lot of interest to grow, and there's a lot of need in our patient population. So at this point, my role in the hospital is actually the endovascular fellowship program director and the PERT program director. So there's a lot of endovascular therapy, and we've been in practice from almost 9 to 10 years now. And for radial to peripheral specifically, we got the first exposure to it around 3 years ago. And since then, have you noticed, as you noticed in your intro, you guys have a lot of talks about it because it's just growing really quickly, which is we're really excited to be part of it.
One of the reasons, so one, it's definitely an evolving practice. And when things are like that, interventional radiologists, cardiologists, vascular surgeons, they actually reach out to us and ask us to do more topics on it. And the more we do, people are just no, you can cover it a little bit better, or, hey, can you talk about this specifically? So we're happy to do it. And just so the audience knows, we take the feedback very seriously.
That's
all right.
great.
So interventional cardiology, real quick, how many fellows do you guys have? How big's the program?
So our general cardiology program is 12 fellows. Our interventional cardiology fellowship is 2 fellows. Our endovascular fellowship is 1 fellow. And we have 2 structural fellows. And 1 imaging fellow. So 14, 16, 18, I think, something like that. That's just from the cardiology department. And for vascular surgery, we have 2 to 3 fellows per year. It's 2 years program. So there's a lot of fellows in a hospital that's a 105 bed, but we are a very specialized hospital. We're a cardiovascular hospital, and I always make a joke that I don't see pneumonia or GI bleed anymore, so I only see cardiovascular specialized patients. So which is really good.
Okay, small hospital, but everyone who's coming through is target rich environment.
Correct. Correct.
Okay, so just general question: what made you incorporate radial into your peripheral practice specifically? I mean, I would say that you probably trained in the era when radial was standard for coronary diagnostics and intervention. So I was curious, like, when did you work radial into your peripheral practice?
No, I mean, actually, this is a really good question because the way when I was in training in my residency and my general cardiology fellowship, which was in Indianapolis and Louisville, Kentucky, really the pathway to coronary was all femoral. In my general cardiology, we had one attending or faculty who was doing radial, and we wanted to work with him to learn that. So 15 years ago, when I was in general training, we really, that was the early age of radial to coronary, and there was a lot of pushback. A lot of people said, well, we've been doing femoral access for a long time, no complication, etc. And when I moved to my interventional cardiology fellowship, we did a lot of radial to coronary, so around 70% of our volume. It was a significant shift, and the reason behind that, because the guidelines for radial to coronary, for coronary intervention has changed to make radial to coronary is a class 1 indication. And that's mainly because of safety, access site complication, and for, of course, same day discharge and the benefit from same day discharge patient and the patient satisfaction. So in practice, when I started, I would say, 70 to 80% of my coronary cases were radial. And we still use femoral for certain cases, like certain CTO cases or maybe bypass patient. And for femoral, for peripheral perspective, I was trained 100% femoral access or pedal access, or a combination between femoral and pedal. When you look back at all the data that looked at radial to coronary versus femoral to coronary intervention, when you talk about access site complication, most of the patient, when you look at characteristics, are, who has more complication are female, older patient, and also patient with peripheral arterial disease. So to me, it makes complete sense to find an alternative way in those specific patients to treat peripheral arterial disease to minimize the risk of femoral access complication. This is how it started. I feel like I was lucky that I was in training during the first revolution wave in the coronary, and now I'm in practice in the second revolution, which is the peripheral side. And we tried brachial, we tried axillary, we tried all different pathways. And as you know, and the audience know.
Yeah, how'd the brachial access, how'd all that work out for you?
Nah, I would say 90% complication rate. There's always the problem with it. It's like popliteal or brachial. We always worried about a complication, But we tried to do radial and we didn't have equipment. This is the truth. We didn't have equipment, and we tried fancy ways. We tried diagnostics, which is easy. But the moment you want to try some intervention, we didn't have the equipment. 3 years ago, that changed. And since then has been a phenomenal journey. You have many companies now, multiple companies has been working on advancing this technology. And we're lucky to be part of, this journey so far.
All right. So without putting the screws to you about, or having to put like one company on the line, what to you was like the big unlock for like when you started being able to really do radial cases, and specifically peripheral cases? Was it a sheath, balloon sizes, or kind of all, or balloon lengths, or everything kind of coming online at the same year or something?
The first most important product that we really needed is the sheath.
Yeah.
I mean, without the sheath, we can't deliver anything. And you can still, for shorter patient, if you go left radial, you can still use some of the available product of 150 shaft balloon or 150 shaft, stent or something like that. Of course, if you start talking about distal SFA and popliteal and taller patient, you get limited. So the sheath was the most important first product. And now we have everything available, almost everything available. We have balloon stent rapid exchange, 200 shaft from 3 different companies. We have stent rapid exchange, 200 shaft from 2 companies. Atherectomy wise, for calcification, we have the Diamondback CSI, and for, mild to moderate calcification or install restenosis or, restenosis lesion, we have the laser Auryon, which is a 200 shaft, we call it Excel. I would say the second major step that changed our practice is the evolution of a drug-coating balloon. Initially when we had the sheath, when a patient who never had a procedure, you want to do a simple drug-coating balloon therapy, avoiding stent, we had to go growing because it was not, in my opinion, was not ethical for me to deliver the patient as suboptimal therapy with just a balloon or a stent if I can go femoral and deliver a drug-coating balloon avoiding metal. Now that's available. One company has it. Medtronic has a 200 shaft. Other companies are coming online. I know many of the other companies are working on the 200 shaft. So it's exciting. I mean, it's every product we get online and we try it and we've been pretty impressed. Pretty good journey.
That's good. I like to hear that. So we're going to jump right into it. In episode 395 with Fritz, you covered what I thought was a really helpful segment just about like getting your sheath down. And if you don't mind, can I have you rerun through that? Like your steps just from like access to getting the sheath and like an iliac or proximal SFA or whatever. And then I'm going to kind of ping off that for like a couple side questions that I had.
Definitely. Happy to. So I will tell you my pathway, but that's not the only pathway. I think the biggest difference between some of the, I'll call it radialists who really do a lot of radial to peripheral is the option of right radial versus left radial. Some of the amazing operators you guys have recently, for example, Dr. Servazova from Florida, I think he used a left radial. Actually, he used a right radial like me, but other doctors like very busy radialists, they go left radial. So that's the first thing. To me, I do right radial, just it's more convenient. It's much easier from a logistic perspective. We recently started doing ultrasound guided just to make sure that we have a nice artery and what to choose between radial versus ulnar. We've done many cases that's ulnar instead of radial because it's larger. We do the small sheet, the Terumo short sheet. We go with the J wire, and my preference is a JR4 5-French 125 shaft. Other people have done a vert. Some people have done a pigtail, but that's just my preference is a JR4 long. And then you just have to maneuver around the arch. Sometimes it's challenging, but most of the time it's just go right down there. Deliver the sheet, the catheter all the way down to the iliac arteries. We do our selective diagnostic pictures after we give 4,000 or 5,000 units of heparin. And then we do our selective pictures. And then if we decide to intervene, I'll put a stiff wire. Usually my preference is supracore. You can use any other wire, but supracore, I think I've noticed it's been very effective. And then I deliver my long sheet. So long sheet, 3 different companies, but in general, anything between 115 to 120 centimeter is the most common used one. If you're talking about, SFA, popliteal, common femoral intervention.
What sheath size is it? Not length, but diameter. It's all 6/7, 5/6.
Yeah, all the companies has 6 French. The only company that has 5 French sheet is Surmotic, which I've used a couple of times in a very small radial artery in small patients, female patients, older patients.
So a couple of questions that I want to ask you for that. So why did you guys recently start using ultrasound? From like your discussion last time with Aaron, it sounded like you were not using ultrasound, but now you switched over. And I was curious why.
That's a good question. We all learn, right? We all learn from our mistakes, or if we learn from each other. So I started using it based on a couple of other really experienced radial to peripheral interventionists that I was lucky enough to give some talks in the national meetings with on the podium. And one of them mentioned why he used ultrasound. It made complete sense to me. For him, the reason we started doing it is we measure the radial artery, make sure it's a large enough radial artery. And if it's not, we try to look at the ulnar and decide if we want to go ulnar in that direction. Sometimes certain patient like dialysis patient or a CKD patient, they may have some calcification in the radial artery, but their ulnar artery actually healthier and larger. That's the main reason.
Got it. Do you have a diameter cutoff for, like, so say you want to go radial and you're like, oh, it's X millimeters, so I'm going to look at the ulnar, or is it more of a gestalt?
Anything less than 2.
Okay.
I think that made me a little bit concerned because you'll be able to get your diagnostic pictures, but I think one will be painful for the patient, or the concern, again, that has not been proven by any trial, but to me, that makes more sense that when I finish, am I going to increase the risk of radial artery occlusion in those patients? So to me, it's much easier to go to an ulnar, larger, more direct. And but of course, with the ulnar, it has a higher risk of also complication just because there's no bone behind it. So we were very worried when we use ulnar. We very careful, and we communicate with our staff to make sure this patient is monitored a little bit longer.
Okay. So that takes care of vessel size. What about pre-procedurally, Allen test or Barbeau test?
No, there's so many data not supporting those anymore. We stopped using it for the coronary. I stopped using it for the peripheral.
Sure. As far as wire, you mentioned using a J. Is that like a baby J or a braided J?
No, I start with the baby J.
Okay.
That's my to-go wire to get all the way there, down there. The wire that I've been more impressed with people just going to blow off all the time is the Benson. Benson is just so floppy, but it goes really nicely through the arch and it gives you some flexibility. But other option will be some, glide wire. But if you're going to start using glide wire, as I told my endovascular fellow, is always you have to watch the end of that wire. You cannot assume it's in a good place. But glide wire works great. I know a lot of physicians, they start with either a stiff glide or glide advantage from the get-go, which is not inappropriate, but you just have to watch it. I preference is a J wire or Benson. 99% of the time works just fine. And then you switch to a stiff wire.
Yep. So you mentioned earlier right versus left. So even though you've settled on right, can you talk about maybe the advantages to why someone might pick going left radial?
Yeah, the older the patient, you start having more tortuosity in the right brachiocephalic, and also their aortic arch become more of a type 3 arch, which make going to the heart easy, but for the leg it become a little bit more challenging. So it's not inappropriate to go left radial on those patients. In theory, if someone had a bypass and they're using the lima from the left side, you want to try to avoid putting a sheet there for a long period of time. Again, that's in theory. There's nothing proven that to increase any risk there. The last thing, if you have very tall patients, so my cutoff to go radial versus left versus right, if someone is 6.2 and taller, I think I prefer to go left radial, just in case I would like to use for example, the IVL Shockwave 135. I want to get somewhere in the iliac and common femoral, maybe the proximal SFA. That will give me around 10 to 20 centimeter length. But otherwise, it's just more convenient to go from the right radial. When we start teaching radial to peripheral, I have what I call the rule of 4.
Okay.
To start that. So the rule of 4 is to know your staff. You need to know how comfortable they are in the setup. So radial versus left versus right is extremely important. Know your equipment. So if you don't know the right equipment, you should not do radial to peripheral, because halfway you don't have the right balloon, you don't have the right stent. It's not right. Know yourself. Make sure you really are a true radialist, or you're someone who want to just do the simple selective cases, and know your patients. So the reason I'm finishing with know your patients, patient with aortic byfem or patient with EVAR, you lose some length on this patient. So when you go right radial, your sheet, even the 119 or 120, may end in the limb of those, either the EVAR or the aortic byfem. So you're really far away from where your work zone is. So in those patients, for example, either I use a longer sheet, like a 149, 150, 145, depends on the company, or I go left radial.
Gotcha. And left radial gives you like maybe another 10 centimeters working room, something like that.
Give or take.
Yeah.
Correct. Give or take.
Any commentary on when you go right radial, you're crossing all the great vessels that, go supply the enterocranial, versus when you go left radial, you're just crossing the vert, or not?
Yeah, that's in theory. When with the studies for the coronary, there was a concern initially, are we having high risk of stroke? There was a theory behind it. We actually published from our hospital, our first 100 patient experience, we had 0 stroke. We published 50 patient iliac intervention, radial versus 50 femoral. We had 0 stroke. We're collecting now 400 patient population in our hospital. And we had 1 stroke 29 days after the procedure. So we're not seeing a trend towards stroke going from the radial, but that's a concern that it's a valid concern. So if you start having, a tortuosity, or you're really pushing your wire in a way that it's too aggressive, a concern for sure can happen for sure. So left radial versus right radial, I think that's one of the reasons people have to go left radial, but there is no data to support so.
So I wanted to talk a little bit about room setup, and I don't know if it differs from right radial to left radial, but whenever you go right radial, is it access and then right arm goes down by the side? So like in practice, like you're kind of working as if you're at the groin?
Yeah, that was my first 200 patients. I used to do that. Then we purchased what's called a star board, which is specific for radial to coronary, and just give you some more radiation protection. So it's the same thing, it's board on the side, and then we just shift it towards the side of the bed, and then you have a board with some radiation protection, and we just do our cases. It feels exactly the same way. Maybe there's a little bit of a difference than when you go bring the arm up and over right to the groin, but overall, really, there's no difficulties maneuvering the catheter or pushing the balloon. You're still working in the same location.
And is there ever a situation, this might be more common with interventional radiologists, but do you ever have the arms like abducted, like kind of out to their, like instead of out by the side, they're kind of teed out or anything?
We try not to.
Yeah.
If I want to keep my staff happy, I'll try not to. Yeah, I mean, it's the only, so what I've noticed sometime when there's a lot of radial to peripheral interventionists who do left radial, they do so for one reason, because this way what you do is the left radial is all the way abducted, and then you put the table, your table at 90 degree or like a T to the table, to the patient table. But even for my left radial, what I do is just I move the arm up and over, and I just work from the left side of the table. I don't work from the right side if I'm using the left arm, it's radiation protection, things like that.
Right, I get that. So we already talked about height restriction a little bit. I think you quoted 6'2", in which case you're going to start really thinking if you're going to be able to reach your lesion depending on where it is.
Correct. I mean, I think if you talk about an SFA, it doesn't really matter because you can put a longer sheet. But I think if you talk about iliacs and certain areas like where you want to use equipment that unfortunately we still don't have a long sheet to, like, for example, IVL shockwave. So it depends on what you think you have to use. So I think procedure planning, like always, it's very crucial in those cases. And we learn it the hard way. We learn it, I just go in, I'm committed, and I look at the page like, how tall are you? And like, I'm 6'5", I'm a, MBA, retired player. So now we ask this question ahead of time. It's part of our timeout if you're going to do, just to figure out where we're going to go with the right radial versus left radial.
Okay. One thing I wanted to touch on real quick, your radial cocktail, if you have one.
It's very traditional, 5 of dipride and 400 of nitro. I give half of it at the small sheet, and second half is when I move the small sheet and insert the longer sheet.
Okay. So I was trying to like poke some more holes into like problems associated with radial to peripheral. There's a little bit of a height restriction. Oh, how about this? This must get brought up all the time. Pushability. So do you still have the same pushability? I guess in theory, the way I see it is like once the sheath is in place, it seems like it would be similar, but
yeah. So that's the theory we're concerned about, and I think what we learned is the right sheath length is crucial. So if you really need to treat an SFA and use 105 sheath and you're really in the aorta, basically you have no pushability. The moment your sheath is in the external iliac, it's exactly have the same feeling, the same pushability as the going from the femoral. You have 3 different companies. They have different design. I've been impressed with all of them. I really can't pinpoint one that's better than the other. I would say the only thing, if I'm going to have to use 5 French, there's only one company who make it with Surmatic. But, you're talking about the pushability for Cordis or for trauma or for Surmatic. They've done an amazing job delivering those catheters. And the nice thing about those sheaths is the moment they're in for good. I mean, they just don't have this back and forth. The other thing that I would say when we go for femoral, and you guys have all had these cases, is when you have someone with a lot of tortuosity and you have a very complex case and you start pushing, and all of a sudden you're pushing, your wire doesn't move, your balloon doesn't move, and you know what happened. The whole sheath is now in the aorta and you lose your sheath completely. You don't see that in the femoral, in the radial. Because it's more straight shot, I'm not seeing that commonly happening. So actually, I prefer radial now over femoral. The few times that I go femoral, it's specifically when we are part of a trial for a device that only option is femoral access. Like we are all part of like 3 different below the knee trials and starting an SFA trial. So for those cases, we have to go femoral just because the product. But pushability, the moment you have the sheath in the external iliac, you're golden. There's really no issue there.
All right. I think it's, I'm kind of done like poking holes in it. I think that's fair. All right.
So, you know what? Well, I'll tell you something.
Okay. Yeah, you poked the hole in radial to peripheral.
I love talking about radial to peripheral because I was a resident and a fellow when radial to coronary started. And, as a fellow, you just listen and you hear people talking. And all these concerns people have for radial to peripheral are concerns that people had in the radial to coronary pathway. Same conversation, the same idea of, I don't have a groin bleed. I've done 20 years of practice. I've never had a groin bleed. I can always get access. I have, why I would change my practice after 20 years going from femoral to radial in the coronary world. You're not going to have enough pushability. You're not have enough crossability. I can't do CTOs. And the Interventional Cardiology Society has did a phenomenal work to show that it's not true. There's plenty of data to say the opposite, that actually radial to coronary is as good as femoral. But of course, the technology has improved. And I think like where we are right now in the radial to peripheral is exactly the same conversation, the same discussion, which is fun. Don't get me wrong. But instead of being a fellow or resident, now I'm in the middle of it.
That's right. You can just fill the questions.
Both ways.
Yeah.
Exactly.
All right. That's fair. So what I'm thinking about for like this line of questioning is, are there any cases though that you just cannot get done with like when you have a peripheral case that you just can't get done from a radial approach, like something like where you have to intervene like below the pop or like certain devices that you might need? Okay. Yeah. Go ahead.
Definitely. No, definitely.
Okay.
I mean, I think it's wrong to say there's only one way and that's the only right way. I think femoral access, pedal access is absolutely important. Especially now, the revolution of CLI treatment and artery reconstructions and wound healing, you have some time to go all the way down to the arch and reconstruct the arch or have to open, some kind of very difficult lesions. And some of the equipment, if you're talking about, for example, TAC stent or the new spur stent or the biobserval scalpel, they're all 135 to 150 shafts. So you can really treat your patient the right way going radially. So you have to be, selective in those kind of cases. If you want to use a supera, specifically supera for SFA or for the popliteal, then you have to go, the femoral or you can do pedal. One issue we used to have that now we had a little bit of a more leverage to it is the cover stent. So most of the cover stents were 7 French and 8 French. And Gore just came out with the version 2 of VBX. That's actually the 6 and 7 are actually in 6 French. So what we have that, I think is 150 or 135 shaft. So I would say for certain cases that I would not go radial, someone has an iliac that's very large that needs to be fixed. So
that's strictly because you might not have the bailout option should you run into it.
Not really. That's actually not the reason. And that's actually a good conversation. But the reason behind it, actually, if I have to use a large stent, let's say a 12 millimeter stent or 11 millimeter stent, those stents, especially if it's balloon expanded, they are require a larger sheath. But, up to 8 to 9 millimeter balloon expanded, you can use the Abbott balloon, and 9 by 29 is a 6 French compatible. So, and you can expand that to 10 or 11. But I'm talking about a very large kind of stent that you require. Terumo just finishing a trial for a 10 millimeter self-expanding stent for the iliacs. We're part of that trial. So as I said, every day we're getting more product that make us able to do it. The bailout, it's a very, very interesting conversation. The first time one asked me that was last year during CVI. And in my theory, I always look at it, I think it's safer actually. Well, iliac rupture is the worst nightmare that you can have as a peripheral interventionist. To me, iliac rupture, iliac perforation is actually safer to manage via radial than femoral. Here's why. If you're going femoral, trying to fix an ipsilateral iliac vein, iliac artery, and you rupture, what you do is you balloon expand, you put a balloon, tamponade it, get access from the other side, up and over, and try to kind of deflate the balloon and get your equipment. because you will need an 8 French sheet to deliver your Viabond cover stent. If that happened while you're radially, the easiest thing to do, the same balloon you had, just pull it up a little bit, inflate it from the radial axis. Now you have the whole time in the world to go get ipsilateral access. There's no bleeding. The patient is stable. You're really not rushing to kind of have to deflate the balloon. You get everything ready and set up. Then you deflate the balloon, deliver the stent, and you're done. We had one recently. It was actually much easier to treat and manage having the radial access than manage having femoral access. So again, people have done it from the femoral for a long time. Iliac rupture is just a nightmare no matter what axis you get to. But this is my theory how I think it's just safer in a way to manage it from the radial.
You kind of mentioned having to get like complementary access. I would still assume that you run into cases where you either need femoral access or pedal access to get a case done. And is that still the case? Like you're still like for all your radial cases, like depending on where you're treating, what you're treating, you may ask them to prep the groin or prep the foot. Same?
Definitely.
Yeah.
Every patient get bilateral femoral prep. The other thing is for safety, patient safety, you can't just assume you're going to be fine. And nothing worse than asking your staff to start prepping in the middle of the case. At the pedal axis, what we do is every SFA occlusion or popliteal occlusion, we prep pedal. And I think I learned the hard way. I'm trying to prevent what's called the rolling eye syndrome. You don't want your staff to start rolling their eyes and you ask it to prep halfway.
Every operator right now knows exactly what you're talking about.
I think the staff are amazing. We have a very experienced staff and they actually start from the get-go. They review the case before we start and they ask me, hey, I know you're going to go radial. Do you want me to prep pedal? And I think it's more convenient for everybody to have that prep. So I do prep pedal 100% of my SFA and popliteal occlusion. Prep femorals in every single case. But I would say 90, we had actually that data published. I think we had 96% of the cases, no matter where the location is or location was, we treated via single axis radial.
96% of the, wow.
96 of the cases. So only have 4% to switch to complementary access or an alternative access. I think the technology has improved, the microcatheters. We only had a Viper 200 catheter. I also don't know who make the Viper catheter, but I'll tell them the catheter should just be redesigned. It's a terrible catheter. Surmotic had the Sublime 200. They're amazing catheter. Terumo's coming out with a 200 Navicross. They're great catheters. We really have 90% of the product we really need. And the new technology with, the Auryon laser, which we started using a couple of months ago, and the Diamondback CSI, the long shaft, has been phenomenal to use to treat those complex patients.
All right, so that's like as good a shoehorn as any to get into atherectomy. Specifically, let's talk about like laser atherectomy. You mentioned the Auryon, but let's back it up and further just talk about like laser atherectomy and what lesions or what patients that you like for that atherectomy device.
Yeah, so the first, when we got introduced to laser atherectomy, we were introduced to the excimer laser from Philips. We use it in the coronary, we use it in the peripheral. It's a great product. It has its own kind of learning curve to it, how fast you need to push, make sure you're not have injecting contrast, make sure you have saline flushing to cool down the heat that gets introduced. And the excimer ISR trial was a great trial, but the outcome was amazing. And so for me, laser has been mainly for instant restenosis cases. Saying that, there are great data for below the knee from the excimer lasers. So below the knee become also more popular. The newer lasers from Philips, the large one, 2.3, and there's some product coming up online very soon. They are good. They are indicated for also calcified lesions. But if you tell me, if I use something for calcified lesion, heavily calcified lesion, I would not use laser. Laser would not be my first choice. My first choice would be something else. It will be either Diamondback, Roto, IVL, other atherectomy devices, or Hawk one directional atherectomy. If I start talking about instant restenosis, Rotorex is a good device, but I think really laser has what we've been using for a long time. We didn't have Auryon, even though Auryon had some data that published And then we started using it recently, and we've been very happy with it. The differences with the Auryon laser specifically, I don't know if you want me to go into it right away or just talk on atherectomy in general.
No, launch into it.
Yeah,
I'm not gonna slow down a good man.
So when we had the Auryon, the question was, why would I have a new laser? Why would I just use the same laser I've been using forever? And having a conversation with some of the operators that have been doing it for a while, Dr. Shamas has had a lot of experience below the knee. And the difference is this is a lower, shorter wavelength laser. It's a 355 wavelength, which is cooler laser than the excimer laser. And because of that, you don't have to flush with saline. And actually, even if you have contrast, there's nothing happened there comparing to the excimer laser when you have this kind of major bubble burst and possibly causing some calcium disruption or maybe complication. So it's really nice when you use it and you take pictures while you have it right there. You're not worried about having to flush and clean it up and flush with saline. So the ease of use has been really good. It's a very, when you use it on, very simple. You turn it on, you wait for a few minutes. Now you have two options, and that's only two options. You have either 50 or 60. That's the setup of how the power of the laser, you want 50 versus 60.
I know that you guys had talked about it already on one of the other podcasts, but has your practice changed as far as like what you put your setting to? Do you run it at 50 and then switch it over to 60 or?
Exactly.
Okay. Yep.
So the biggest difference between 50 and 60 is, of course, if I'm not able to cross a lesion at a 50, then I have to use 60. I always like to try the 50 first and see how it goes. Really, we're still learning. I don't know why would I just choose 60 from the get-go.
Yeah.
And maybe when we do, hundreds of cases, maybe we can have our own algorithm. But the issue, if you go 60 directly, so they have a 10 minutes timer, and that 10 minutes timer, it was meant for 50. So at 50, 10 minutes after that, it will shut down because they're worried about the integrity of the device. When you do 60, it actually gets you much less time that you have to utilize. So I think to me is I start with the 50 and I do, a minute or two. And if I take a pop, if I have the result that I hoped for, then I don't have to go to 60. If I can't cross, I go to 60. I like 60 a lot in end-stage stenosis, especially in large vessels, because I try with the 50 first, couple of runs, and then I switch to 60. But if you ask me, why would I go directly to 60? I really don't know the answer for that. I try 50 all first, and then if it doesn't cross, I go to 60.
Well, it's like maybe one of those things, like with enough experience, maybe you'll figure out the answer, and we'll talk to you. We'll have you back on the show for another episode if you figure it out.
Definitely.
Devices come in different sizes. For the two larger sizes, I think those are the ones that come with like aspiration also.
Correct. So
Okay.
so this is one of the advantages. They don't have that in the Radial, what's called the XL.
Oh, okay.
So they don't have that in the Radial. So again, as we're talking about, if I want to do specific things that my patient require, then you still have to go femoral or pedal. So, you don't have the XL in that. I think they have 0.9 and 1.5 in the XL, which is the long sheath or the long shaft. But the larger one have a suction capability. When we had the discussion with Dr. Shamas, one of the things and his finding and his 30 days paper just got published in American Journal of Cardiology, AJC, recently. And the outcome is very impressive. The dissembolization, the risk of dissection, it's just very minimal, if any. Of course, he has 60 patients or so it's not a very large trial. But again, all peripheral arterial disease trials are not large trials by default. But it's really promising. And from our experience, we've been impressed. I mean, we haven't had that, disembolization. I don't use filter in this laser, but almost all other atherectomies, I use filter.
Filter protection.
So filter protection, disembolic protective device. So to me, if I want to go radial, I don't have the filter option. So it's great to have a device that I'm not worried about using a filter. So if you look at all other companies, all their devices, they advertise it that the disembolization is not a really big deal, and maybe you do not need to use an embolic protection device. But really, a real world experience has taught us differently. We've seen disembolization in almost every single product. So to me, I use a filter in almost every atherectomy, except Auryon laser because I have not seen that disembolization in my practice. And the data we're seeing from, Pathfinder registry, with the data we're seeing from Dr. Shemes, the paper, just been very promising.
So you mentioned in the longer shaft lengths for if you're going radial, you only have the option of the two smaller lasers. But if you could just educate us on, like, when you're choosing your laser, like the sizing of your laser, do you want to go as big as possible? I actually just truly don't know the answer. Like how you pick the sizing of the laser whenever you're finding like lesion to treat.
No, that's a good question. I think the question is what type of lesion you're treating.
Okay.
Are you treating de novo lesion? Are you treating instable restenosis lesion? Are you trying to use the laser just to give you a pathway to pass something through? So that's what, if I'm nothing crossing and I really need something to cross, so you just use the smallest laser possible. You just try to create a pathway. For me, I don't use 0.9 unless I'm doing below the knee work. My standard would be 1.5 almost in most of my cases. And 1.5, I can use it in the SFA, popliteal, and actually below the knee in the proximal segment. When I'm talking about instable restenosis, I think that's where you already have a stent there. Usually it says 6 to 7 millimeter stent. So that's where the larger size laser with the suction capability comes very handy, because this is not just plaque, this is scar tissue, new hyperplasia or new intimal hyperplasia. So those are the ones that have a higher risk of disembolization. So having that extra layer of therapy with suction or aspiration would be very helpful.
Any things that you've learned, like with your experience using laser atherectomy, that is like built in like knowledge for you now that you could share with the audience? Like, hey, these are some things that either troubleshooting tips or things that have made like using the device a little bit more facile and a little less fussy.
That's a good question. So one thing that I think the design of the device would have been better in the radial to peripheral, to me, RX should be the standard. Over the wire is a really challenging part because we really do not have good quality wires that's very long. You need 400 centimeter or longer wires. So in that category, you only have basically two wires. You have the glide wire 400-035 from Terumo. You can't use that laser. It's an 014 laser. So it's a 014 system. Or you have the Viper 475, and Viper wire is not meant to be used for delivering stuff except the, orbital atherectomy. But we use it 100% of the cases. That's the only wire we have. Because even I want to do just simple balloon and DCB. Yes, my regular balloon from radial to peripheral is a rapid exchange, so I can use it over any wire. But if I want to use a DCB, Medtronic DCB is a 200 shaft over the wire, so you absolutely need a 400 to 475 shaft. So because the quality of the wires we have with Viper is not the best for that, it's not meant to be for that reason. I think sometimes if you have not a good support, if you choose the wrong radial sheath length, I think you may have a hard time crossing or just delivering it to it. But what we had really were very pleased with, that the moment you get there to a point where you can turn the laser on, it just works like magic. It's really get through. It helps. I tried one case where I put my Viper wire across with this is why I did SFA CTO 119 or 120 shaft sheath, used a Sublime 200 microcatheter, crossed with a Viper with the Command 018, switched to my Viper wire. I tried to push a balloon, just a regular rapid exchange balloon from, I don't remember what company, couldn't cross it. So I said, okay, let's just get the laser and see if I can just get a laser through. So the laser, to get it to there was just a little bit of a challenge. And then the moment I got it there, I said, it's not going to cross. There's no way. And I turned it on, and it just flew through it. So the laser did what the laser is supposed to do, right? But the laser design was not meant to be delivered over a Viper wire. And that's not their fault. That's just, unfortunately, the limitation we still have. So what I would love to have all these companies that's spending money on building radial to peripheral, one of them just spend a few more $1 million to get some wires. That's 400. That's good quality.
I suspect they're going to be on their way.
I hope so.
Yeah.
But I don't, every time we talk to companies, all the big companies, I don't think that's, on their most important, like number one agenda. I think there's other, they're talking about, the rapid exchange versus not versus how long. The other thing is, I would think all the other companies, or even Medtronic, if they want to redesign the 200 shaft balloon, it absolutely has to be a rapid exchange. Over the wire with the Medtronic just is not operator friendly. And the argument is you really don't need for a DCB to be over the wire, because this is going to be your last step. You already atherectomized, already ballooned. You should be able to deliver. So a rapid exchange should work. And so hopefully, they redesign it, and hopefully all the other companies who are coming up with the 200 shaft DCB do the same. But anyway, going back to Auryon, sorry, it's you go in a rabbit hole there, but it's a great device. Really, I'm very impressed with it. I've used it both femoral access and radial access. Again, it's a first design for the radial. I think we'll see if maybe try it for some time and change it to a rapid exchange will make a difference. Not sure. But having a long shaft, it has its advantage and disadvantage.
Fair. Earlier, I'd asked you what cases that you don't like for radial, but switching gears a little bit, what I want to know is, are there any, like for people who are radial resistant, are there any cases where you can say, look, doing this case is just so much easier radial? Like, I think those are always nice to have those cases. Like you said, you're always going to have people who are just like, they've been doing like femoral access for 20 years and it's hard to be able to get them to switch. But like maybe like a subclavian intervention or something where you're like, this just makes so much sense. Like have this tool in your tool belt to like go to.
Yeah, definitely. No, I think so. We have great operators in our hospital. We're very lucky. Our hospital is very unique. We all work together. Our interventional cardiology department, who does a lot of endovascular work, and our vascular surgery department, we work very close to each other. We enroll trials for each other. We have, we take care of patients. And I'll tell you some of them who great femoral operators have used radial for specific cases. So I'll tell you those cases. So some iliac cases, iliac occlusion, it's absolutely much easier to cross radially. When you go ipsilateral, we have tendency to go with a dissection plane right away. And then you have to use either an outback or pioneer to recross. And if you recross too high, then you commit to a cover stent or reconstructing the whole aorta. And if you have a flush occlusion in the iliac, going up and over become very, very difficult. Radial has been really a game changer. I've had many cases was referred to us for a second or third attempt after failing femoral, and it just really walk in the park. And I think always happy to share that with the audience if anybody want to look at those cases, and we can talk about it a different day. The other thing is you said a subclavian. My subclavian, crossing subclavian retrograde, it's much easier, and the case takes shorter time, and patient go home in an hour or so. You can nail the ostium. You know exactly where the ostium is. You can IBIS, you can mark it. You can just put your balloon expanded stent right in the ostium, and you can get it really flush to the ostium instead of stenting it from the femoral and always have like 4 struts in the aorta, and it's almost impossible to get back to it.
Sure.
We love renal and celiac from the radial because the way they direct. So, if the people who does, with the old way of doing, some of the EVAR with the chimney technique, they use brachial all the time. A lot of people do brachial for the celiac artery and the SMA. Going radial and putting a sheet that's 85 or 105 sheet, give you all the option you need. You can IVL it, you can IVIS it, you can cover stent, you can do everything you really need. And for the renals, it's just much easier and much simpler, and it makes complete sense to have your stents facing upward towards where the flow is, then downward against the flow. Common femoral in cases where the other femoral axis is not an option. Again, everything else I want to say, the physicians who do a really good work with pedal will say, well, I just go pedal, which I'm not saying that's the wrong way to do it, but I think pedal has the disadvantage of really taking pictures. There's a limitation to that. But I think if you have someone with aorta bifem bypass or someone had an EVAR and you really can go up and over, it's very nice to go radially this way. And it's just everything else become the traditional pathway. But those are the cases that I would say radial has been really game-changing technique.
And I did want to echo that sentiment in that, we're not on the podcast saying like, you have to go radial, radial's everything. But, to me, it's always just made sense that be able to go radial, be able to go pedal, be able to go femoral, and, choose whichever is right for your patient, your lesion, whatever you're treating, and be able to do all of those things safely. Just only makes you better.
No, definitely. I think this is, what the discussions and argument that happened in the radial to coronary 15 years ago started, because you had two side of the aisle. One said 100% femoral, one said 100% radial. And in reality, that's not true. You always have to be capable to be able to get access in both. And again, pedal is extremely important. But I would say, every operators want to do the case, go home, and never hear back about a groin bleed. Everybody would do groin access with, or, closure devices. All the closure devices data showed no change in bleeding percentages or the percentage of bleeding with closure devices. It's actually more patient satisfaction and early discharge. So still with the closure device, we use it a lot, but still, I'm still worried about the groin access. Radial, not too much. Pedal, I think if your staff know how to manage pedal, it works great. But still, if a pedal complication happened and you have a bleed that's not recognized, you're talking about a compartment syndrome, which is a big problem. I think a good operator should be flexible. A good operator should not treat every patient the same way. You can't eat every food with a fork. You have something you have to eat a spoon. So, but I mean, what percentage you want to do radial? What percentage you want to go femoral? That's completely up to the operator and their comfort. But I see the radial being very popular and more people using it. The more and more of the younger operators coming to practice and who are very comfortable using radial for other reasons, I think it will be a great pathway to treat patients.
Well said. Wrapping things up, post-op instructions, or maybe it's to staff, like for post-op instructions, as far as like how long you keep them, site checks, deflation protocol, or also just like, what do you tell your patients like before going home, like how long before they can lift a milk jug, or a little bit of just like what the post-op looks like.
Nothing different than radial to coronary. Exactly the same protocol. There's really no concern about. We looked at our data. Our radial artery occlusion from radial to peripheral was not more than any radial to coronary, which is less than 3%. Ours was like a 1.4% or something like that. I think just traditional way where we do it. Each hospital has their own protocol. Even in our hospital, each physician had their own protocol. This is an intervention. So for our hospital, I think the standard, if I'm not mistaken, 2 hours, and you start deflating the TR band or the VAS band or whatever device you're using, and then home in 2 hours or so, something like that. I'm a little bit more on the conservative pathway. Even the radial to coronary, mine is 3 hours before you start deflating. Post-care is, I think, the first day, just take it easy. And I will just simplify to the patient that we have a written protocol. I really don't memorize it. But what I tell them, I'll say no more than 5 pounds for 5 days, just something that they can memorize really quickly and not having to worry about it. Can you have access complications? Of course you can. You can get access complication from any procedure you do, as long as you're disrupting the integrity of the skin. I think the biggest concern you have is the radial artery occlusion. Most of those are asymptomatic. I think having bleed because the TR band or the VAS band was deflated sooner than what you wanted to, that can happen. But really overall, the concern when a radial access complication happen, it's much less than when I'm concerned about a femoral access bleed, and the rate is much less anyway on those patients. Yeah, I mean, this is basically what we would tell our staff, patient, and the nursing staff as well.
Okay. Any good articles or helpful resources that you have liked or have directed maybe fellows to for, hey, this is like a great article that can go through like radial access technique, or this is a great article for laying out some equipment that you might need for, a peripheral case with radial? Any articles or anything you can share with us?
No, I mean, unfortunately, there's nothing that's very available. There are a few articles. There's Journal of JSky that had a really nice paper recently, maybe like 6 months ago or so, with 120 patients, prospective single arm patients to look at radial to peripheral, was multi-center, great operators, but that's all of this data was even before the DCB was available. I just looked at the possibility that success rate and the safety, and if you read it, I think it just reflects the true real world story. It's very doable cases. But that paper was really the early experience with all those operators. Even those operators now have moved to doing more and more complex cases. That's from JSky. For Auryon itself, the Pathfinder Registry 1, there's some data there that Christian Mass has published many papers about the Auryon laser and Auryon laser below the knee. I think that's something that's worth reading. There in the Sky meeting, the society meeting we had recently, we've given a couple of talks about radial to peripheral cardiovascular innovation conference. Last year, we had a couple of talks about radial technique step by step. You can have that. You can see that online. That's available online as well. Yeah, I think those just a combination of a few things. That's something maybe we should work on as a project to write a paper to talk about basic step by step how to switch from femoral to radial. I think that's a good project to work on.
All right. Or you can just come on, do a couple more BackTable podcasts. We'll get it. We'll cover it all.
Yeah, you guys, if you guys happy to have me, I'm happy to be here.
Okay. All right. Any final thoughts? Anything that I didn't ask about, Sam, that you would have either like to answer as far as radial peripheral or about the laser or about laser atherectomy in general? Anything? Or we cover it?
No, I think, again, the best operators in the country are operators who do not have one technique for all patients. I think even when we're talking about a laser, Auryon laser has been really great addition, but all other atherectomy devices should be available. And we're hoping that this podcast and other podcasts and some publication open the eyes for, the companies to start really investing heavily with radial to peripheral. We still need products that we don't have available, certain type of stent, wires, extremely important. And we'll just hopefully more operators start using radial and we learn from each other. And happy to hear from other people who just started, the challenges that they had, the concern that they had, and maybe the success cases also that they had. And as I told you, every time I go to a conference, even as a faculty or speaker, I come back, I learn a lot from other people because we all do things differently. And thank you for the podcast and the team and the whole BackTable team to bring this topic to the light, because I think it's important. And all the topics you guys bring, we learned from this podcast. And I think the only thing is that this podcast is bringing a challenge, is that our staff is not liking us every week to come with a new idea. I think but we hear it, someone is doing it, we're going to have to try it.
Yeah. I got you.